who's again a medical director and chief surgeon of the Center for Vision and Eye Surgery, Chennai, and again a very versatile surgeon with a lot of innovative tips. And he is going to be showing his video to us.
Thank you, Chitra. And I'm just starting the video directly. This is about a customized toric IOL in a keratoplasty patient. And this patient had actually undergone a therapeutic keratoplasty for fungal keratitis 6 months back, and then came back with significant astigmatism with a clear graft, but also with a hypermature cataract. And at this point, we decided to go ahead with the surgery. But if you look very carefully, there is a membrane on top of the cataract, which is an inflammatory membrane. So that was a challenge I was anticipating. Of course, the surgery will be done with the help of viscoelastic and specifically chondroitin sulfate to make sure the endothelium is protected. Now, I did use a punctorexis, and Mohan Rajan inspired me at that moment of time to actually try this. And because of the thick membrane, rather than doing a simple rexis, which would have been very tough with the fibrotic capsule, I decided to just make a small opening. And since it was a very soft cataract, in a hypermature cataract, it's actually quite important only to make an opening, make sure it's regular. And then I went ahead with only the IA. And even since it was hypermature, but there was a very thick cortical matter, and it took a bit of irrigation, bit of movement to make sure we could actually aspirate it. Remember, this is 6 months post-surgery. Patient has very less vision. The inflammation has come down. And this, actually, you can make out the pigments on the anterior capsule. As you go around, gradually the cortex actually liquefies, and then you can take it out. It's still a struggle because it's a very, it's not like a standard opacified cataract. This is a very, very inflamed eye. It's more like a uveitic kind of cataract. You can make out that it's a slightly oval rexus. I'm struggling here actually to extend and make the rexus longer. But because it's fibrotic, you do not have any control like you would in a normal cataract surgery. And here you can see superiorly, because of the iris synechiae, I'm still not able to make it large. But then I decided that however large I could make it, this seemed a fairly large enough rexus to actually place the toric customized IOL. We used a customized plate haptic in this, and it had about 8 diopters of astigmatism. We did just remark it, and before we went ahead, remember that the incisions in post-keratoplasty patients has to be a limbal incision. It cannot be clear corneal like we are used to, and it needs to be a more limbal than, or if some patients, some surgeons even prefer scleral incision. And in a 2.8 incision, it's fairly easy to insert this plate haptic. Remember that the leading haptic has to go under the rexus, because it's a slightly smaller rexus than what I would have liked, but a bit of a struggle. We realize that sometimes in a tight haptic, the lens doesn't open as well as you would like. So this part, I am struggling with the lens dialer to actually put it in. Now, this is important in plate haptic because remember that the second plate haptic have to go in together rather than trying to dial in like we are used to in a reverse normal J loop or a C loop. That once you have it in place, the advantage with the plate haptic is movement is actually very, very less. You can see it's fairly well aligned. You have a bit of places of iris atrophy, bit of synechiae. In the advantage, of course, is that it's not going to move. That is some residual cortex. I realize I go back in and then try and aspirate those few areas, fibers of cortical material. Very important that you suture these wounds post-op. The graft is clear, the lens is placed. He has about 6/12 vision, which I feel is very acceptable from where we started with a fungal keratitis therapeutic keratoplasty. Thank you so much for your attention.
Wonderful video.
Fantastic, fantastic, Dr. Anand. Yeah. Unimaginable that in keratoplasty with cataract of such a magnitude, you can give 6/12.
Yeah. How did you do your biometry, Dr. Anand?
Good question. We did repeat it. I did put an image of the pentacam. We did the average K across the pupil, which is a 3 mm zone, and that was taken as the average K. And remember that we are not trying to correct all the astigmatism. The aim is only to give them good, reasonable vision. But we have done good studies on keratoconus patients, Dr. Chitra, and it is possible to get reasonable keratometry readings if provided you take an average K and don't try and correct the whole amount of astigmatism. You're only correcting a part of the astigmatism. I think that's an important.
What would be the formula which you would have used?
In this, this is SRKT. But if you ask me now, this is almost a year plus old. Now we have shifted almost for all cases for torics, we go for the Barrett's. So that usually gives good results.
Yeah.
Anand,
Post RK.
Can I have a question? Ask a question, Chitra?
Yes, yes.
Yeah. But I just want to know, because there was Cynic K, no? Why you didn't release the Cynic K before you did the capsular access?
That would be an option, but it's a very thick fibrotic band. In post keratoplasty, Dr. Mohan, it's not like a uveitic Cynic K. These are actually very, very thick, because if you do remember what happens with fungal keratitis is those form over the iris, they go under the iris. So during the first primary surgery, when I did the keratoplasty, I removed all those membrane. But since there are some fungal filaments, and when you're treating with antifungals, there is a fair amount of scarring. So it's not a very simple Cynic K, but I felt it was more important in rehabilitation rather than trying to remove all Cynic K. And the lens went into the back, so I decided I was okay with that. But what you're saying, as in terms of releasing to make the rexus larger, is a good suggestion.
Yeah, because once we remove the membrane, normally we don't see these membranes on the slit lamp, but under the microscope, we see these membranes. So it's something like a micro level membrane. So once you remove the membranes, the Cynic K, some of the Cynic K can get released.
This is true in uveitic cataract, but in therapeutic, that part is
obviously it's the inflammation which is causing this problem here in this patient.
Sure. I agree with that point.
Yeah, puncturexis you did well. Only thing is, I find your probe a little tangential. You need to go a little vertical. If you want to punch actually, and also emulsify the nucleus, you need to go vertical, as if you are going into the anterior vitreous.
What are your parameters when you use your puncturexis?
Puncturexis, you use about 50% to 60% continuous phaco power. Continuous phaco power, and about 350, 400 millimeters of vacuum. And aspiration flow rate can be anything. It doesn't matter. So
yeah, I agree. I use slightly, because this is a hypermature, I used fairly lower parameters. My vacuum was only about 100 with about 40%, and I used a longitudinal phaco. So I think the longitudinal phaco rather than pulse or burst is an important tip. I keep slightly lower vacuums because in a hypermature, what is important is to prevent the runout. So 200 works well for me, but experienced surgeons like Dr. Mohan, Dr. Chitra, I'm sure they use slightly higher vacuums.
No, I don't.
Can I make a comment?
Dr. Mohan, Chitra doesn't do puncho, but she punches me.
Dr. Mohan, can I just make a comment?
Yes.
Yes.
Why do we need 50% power? After all, we just have to make it punch the anterior capsule with little bit of the...
No. Please understand. There are two mechanisms for this puncturexis. One is you are using high vacuum. You are touching the thing and opening up.
That is okay. But why power? Why 50%? Why
50% phaco power is to emulsify the nucleus. Please understand, you emulsify the nucleus. You make a small trench there. So, in that area. So, what happens is you debulk the nucleus and prevents the nucleus, because these nuclei are all very bulky. They'll come forward. So, you want to do a small
decompress also.
The nucleus, push the nucleus
and decompress. Back.
And at the same time, you are decompressing the front and the back compartment.
So now we'll move on to Dr. Balla's video. No more.
Thank you so much.
Yeah, Sunil, please.
Thank you very much, Dr. Anand. Thank you very much.